So here's presenting a technical note on removal of a broken interlocking bolt of an intramedullary nail in the tibia which got stuck in the medullary canal. We do not have any conflicts of interest and we do not have any financial funding whatsoever. So a 40-year-old male was brought to us after 5 years of having undergone an interlocking nailing for his tibia fracture. And on presentation, the patient had a discharging sinus from the distal end of the nail, and proximally the knee range was restricted, which was 20 to 90 degrees only. Clinically, there was a discharging sinus, and upon examination by means of radiograph, a varus malalignment of the distal segment was noted, and the skin seemed to be having a discharging sinus from the point of angulation. So the patient was kept on a supine table and attempted to first remove the proximal locking bolts, followed by which the nail was planned to be extracted. So while a reverse hammering maneuver was initiated after having removed the proximal locking bolts, it was hoped that the broken bolt from the distal end would slide alongside from inside of the medullary canal. However, after having passed the tibia midway, it was noted that the broken bolt was toggling and angulating from its original position in relation to the long axis of the tibia. It was alarming as the possibility of a broken intramedullary interlocking bolt was increasing, and given the present scenario of an infection, we could not afford to retain the broken implant inside. However, upon extraction of the nail, the broken bolt on the inside seemed to toggle and wouldn't come out easily. Eventually, the broken part of the interlocking bolt remained inside while the nail was easily extracted. Hence, initially, an extraction by means of using a 1.5 mm rush nail was attempted. However, the broken bolt slided and could not come out easily with just one rush nail. Another attempt was made, however, in vain. Hence, an improvisation was made by using the first 1.5 mm rush nail and the second 2 mm rush nail in order to extract it. Both of these were placed at 90 degrees to one another with the hope that it could easily do the job and the extraction would be a successful one. Since it wouldn't move and toggle over continuously, the 3.5 mm rush nail was again used in order to hold it and pull it along with the 1.5 mm rush nail. The longitudinal alignment of the broken bolt and the lack of friction in the intramedullary compartment of the tibia would not allow it to be retrieved easily, even with the help of the 1.5 and 3 mm rush nails that were primarily stacked in opposite directions. Another attempt was given by using a 1.5 mm and 2.5 mm combination of rush nails in order to retrieve the broken bolt. However, the same issue prevailed as before. Finally, two 2.5 mm rush nails were stacked together in opposite directions with the hope of its retrieval. When that attempt failed, one 1.5 mm rush nail and two 3.5 mm rush nails were stacked in opposite directions in order to make sure that there is no scope for toggling over of the broken bolt or slipping away while attempted passage for retrieval. As the two 3.5 mm rush nails and the one 1.5 mm rush nails were stacked very tightly together, upon attempted retrieval, the passage seemed to be a bit more convincing than the previous attempts. Upon its retrieval, the CM images showing that there is no retained intramedullary interlocking bolt is displayed here. These are the images taken in the OT table after having retrieved it from inside of the tibia. Here we can see the broken intramedullary interlocking bolt and the interlocking nail of the tibia, which was inside of the patient's leg earlier on. Here is a sawbone model which shows that with the help of just a 1.5 mm rush nail, the longitudinal axis of the broken bolt tends to slide over and does not allow for ease of retrieval. Here is a sawbone model demonstrating that with two rush nails of different diameters, again the same issue arises. However, since this is a sawbone, the friction is higher and the chances of retrieval are better. However, in the human body, there's tendency for the broken bolt to slide and not be retrieved with as much ease as it is shown in this video. However, when three rush nails, that is, one being 1.5 mm and two being 3.5 mm, are stacked at 90 degrees angle to one another, the chances of retrieval of the interlocking bolt which is broken is much higher and can be done with greatest ease. So this is a demonstration of the three rush nails which we had stacked together and held it in this particular configuration in order to retrieve the intramedullary interlocking broken bolt. So this case was presented so as to explain the ease with which the methods readily available in the operation theatre can be adjusted according to our needs without any sophisticated instrumentation whatsoever in order to retrieve the broken bolt. Also, the fact that it has a very short learning curve and a little bit of dexterity does all the trick necessary for retrieval of the broken bolt. Thank you.